That's phenomenal. Thank you so much. I know a number of you are probably working on your own questions. If you have a note card or if you need a note card, let us know to write down a question. I'm going to start with a couple myself, and then as the questions come in, I'll go through what comes in on the note cards. So all of you offered really compelling anecdotes about what the path forward is for addressing and promoting a child's well-being. Some of the partners out there we already have, or some of the potential partners. I'm going to start with take a point Andy made and actually refract it back to all of you if you would think about this. And my question is, how do you, either the work you are doing in particular or the work that you know of happening, right, in any area, how do you build power in communities that can best articulate what they need themselves? Right, to Andy's point of, don't sort of drop in and tell me what I need and perhaps shame me about what I'm doing wrong and everything else, when there are all these tensions, right? There are all these pressures on doing the right thing. And then to Tom's point about how healthcare access isn't just about affordability. Sometimes it can be about transportation. Sometimes it can be about language or culture. That I think that is a really important point to drop. So given that a number of you came at this different ways, at the end of the day, the power of people to advocate for ourselves is some of the most potent power out there. So from your vantage points, given your areas of expertise and the communities you're working in right now and the communities you're a part of right now, how do we build power in communities so that the community itself can best articulate what it needs? And I'll let anyone kind of jump in, since Andy was the first person to sort of explicitly lay it out there. You're welcome to come back into that too. Tom?
I'll jump in. So I've had the luxury the last 10 years to be on the St. Paul Federation of Teachers bargaining team. And most of these issues that we just discussed during this panel already all came to our members. And the first thing that we did was to go out to the community and say, can you come together with us, sit down, and once again have a courageous conversation about what our schools and our kids deserve in St. Paul. We brought in anyone who would want to sit with us, NAACP, Faith Base, Isaiah, and said, let's have a conversation about what our kids deserve and how can we sit down together so they can be successful in school and later on in adulthood. And then what we did is we came out with a campaign slogan, because our goal was every time we would discuss things that were important for us from the membership side, we referred to our research-driven data that said, this is what our parents want. This is what our community wants. This is what they believe is important for their kids, not us telling them what they want. Andy mentioned it multiple times. You have to ask kids what they feel is important. So what's important for a doctor when someone comes in with a broken leg is, I need to set this break so it heals correctly. But like Andy mentioned, when that student just seen a horrific accident, their diagnosis really is the trauma that they had. They don't care about the broken leg. They care about, I just witnessed my friend get killed. I just witnessed a car accident. So it's bringing people together in your community, figuring out what the issues are, and really focusing on that as your drive to what's important. And we've seen the success. So when we go to the school board to say, this is what our kids deserve, whether that be more interpreters because we have 55 different languages in the St. Paul schools, or if that's more counselors and social workers and speech clinicians and psychologists and psychiatrists, we say this is what our community wants. It's not what Tom wants. Of course, if I say more nurses, they're going to say, well, yeah, Tom's a nurse. Of course they want more nurses. But when the community drives the conversation, that's the power of putting it back into the people.
Olga?
Yeah, I just want to add it. So I think when we talk about community, obviously we mean many things by that. And so if I was going to slice that up in a particular way, I might say, well, we've got organizations or institutions that represent the perspective of specific residents, right? So you might have, refugee and immigrant organizations. You may have, parent advocacy groups. You might have faith groups, and they have very direct lines to residents who then can tell them things, and then they can represent those as community. And I think that is a very valid and it's a very good way to get a sense of community. Then you've got, going directly to young people, going directly to families, and that takes a real commitment too. I think that part of what I want to say is, I think a lot of us have done and attempted, and our heart is really in the right place around trying either of those pathways to getting to hear about voice directly from those who are impacted. But I do think that part of it is paying attention to the structures that allow the voices to come regularly. These sort of one-off, because we have a grant and we want to do focus groups with families, and that can be useful as long as we're very transparent about this is what we're doing and it's a one-time thing. As opposed to, really in what ways are we allowing young people? And I think, I look at Baltimore and, we like to kind of say all the bad things going on in Baltimore. Baltimore's got a lot of great stuff going on. And I say that because I'm married to a Baltimorean, so I have to say that. But, right, it's in my prenup. And so, but I think that it's paying attention to those structures. How are we regularly doing that? Are we creating structures for parent advisories? I worked with a school district where they really paid attention to the creation of parent advisory groups, where those parents were brought together, had no experience impacting processes at a school level, at a school district level, but they were supported and coached by staff, and to feel that they were empowered and to come together very regularly to give their opinions and to be a part of solutions that were coming forward. But you have to make a commitment to doing that if we really care about those voices coming forward.
I just want to add one more thing, that we have to be really careful, and I probably did it when I was talking about not using community with a capital C. Right, that talking to, you don't talk to community, because community isn't a thing, it's a place, and community members are what's really important. And it's so challenging to get to a broad cross-section and a representative sampling of community members when you're in a place that, in Baltimore, we have something like 250 neighborhoods. And the same thing goes with young people, avoiding the capital letters in front of young people. Because we have a Mayor's Youth Commission. They're awesome. They're an awesome group of young kids who have access to the ability to be on the Mayor's Youth Commission. And when we do focus groups in school, we miss the entire population of kids in Baltimore that don't go to school. And those are the ones, when we're talking about necessary interventions, those are the ones that we need to hear from. We don't know how to get to, so we just ignore. Right? And so I just want to caution us when we talk about power that, I need to be very careful about what letters I capitalize.
I think those are all really potent statements. I really appreciate that.
Can I jump in real
Absolutely,
quick?
please.
Okay.
Thank you.
And of course, I'm going to say we're different. Like everybody in the room is going to say their organization's different. I work for a board that's made up of 6 state Medicaid agency reps around the country, 6 state Department of Education folks around the country, and 5 school corporation representatives from around the country. And in order to figure out how we can make this mechanism of reimbursement work, it's our impression is that's who has to be at the table at the national level. Now, we partner with CASE, the Council of Administrators on Special Education. We work with them to put out this little fancy book about how schools bill for Medicaid that's supposed to be, a 6th grader is supposed to be able to understand this. You can't talk about Medicaid in an understandable way, but we work with CASE to put this together, to basically for schools to use to not only educate their staff, but also to outreach the community. And that's basically where we, from a national organization, again, we partner with CASE, we partner with the National Medicaid Directors Association, the Association of School Administrators, NASD, the Special Ed Directors Association, AFT, CMS, the Healthy Schools Campaign, and USDOE. And then we also work really closely with very specific state Medicaid agencies and state legislative bodies. And when I'm talking with those local state folks, my big message to those is you have to bring up the school people. Not only the school people, but you have to bring in the parents. And the parents will be that actually will make this change happen. Because I went and saw, like I mentioned earlier, Representative Guthrie today. Now, I was lucky enough that I am one of his constituents, so he will listen, but I went in with my name hat on. So I have an agenda. And my agenda is bigger than just little Johnny or little Sue. When the parent talks to them, they really listen differently. That's where they can, and whether it's influencing your local politicians or your state politicians or your local school boards or your teachers' unions or whatever it happens to be, it's those parents that the ones that can make the change happen.
Excellent point. Thank you so much. I have a couple questions here, actually going back to the idea of school-based health centers, and they're all sort of. I'll read through and see what thread you'd like to sort of grab onto, but essentially to sort of tee them up, I would say all of you touched on the opportunity posed by some sort of school-based care, right? There is a convenience of that as a place where young people, the people whose well-being we are trying to promote, convene, right? It is a place where you have them for a while. It is, so there are some access barriers you can remove, perhaps not all of them. Thinking back to Tom's example when he introduced himself, talking about Tom being the single school nurse in a building of 2,000 students, right? That there are barriers to even the best care that might be presented just in that sheer volume. And also hearing what some of the really potent examples of school-based health center success are. My question is, given that those are some of the most compelling arguments, are there other compelling arguments you would make for school-based health centers as comprehensively as you've described them? What message would move the needle and foster the creation of more school-based health centers around the country? And who holds the power to break that open right now is one of the gists of the question. And so how do we get there? Would be the last one.
I'll take a stab.
Okay.
I think there are a number of potential opportunities, and thank you for the organizers for having included the paper that I did, so you could read a little bit more in some of the references that I have there. But I think in the case of school-based health centers and in the case for school mental health, which is the other area I really focus a lot on, I really promote the idea for communities that can do this of really a school-community partnership as a way to build capacity, right? So to look to school districts alone as the system or the structure by which we have to bring forth all the care provision is really unfair, inappropriate, and that isn't the only way to do things. Now, in some districts, they are able to do it. They're able to build capacity from within the district to create school-based health centers, to do school mental health programs, crisis management teams. They can do that. They have, LA, USD, other very large districts can do that. Many, many districts cannot. And so it's really then taking a look, as a lot of places have, at what those assets are, who those providers and those institutions in the community are that can partner very meaningfully with schools. And so in many cases, in most cases, school-based health centers really are, as I said, a partnership between the school system, and a sponsor agency. So there we're talking about, hospitals, we're talking about community health centers, we're talking about, federally qualified health centers, and departments of health. We will have entities that will sponsor, that will be the ones who really will identify and provide the providers, the clinicians, and the preventionists, and those professionals to actually be located in the schools, however they're going to arrange the number of hours and all those things. So much of the power of whether this is going to work falls on whether those sponsors feel that this arrangement is actually going to make sense for them financially. Now, not everyone's going to go into it with, well, if I can't, I'm not going to make money. But here's the problem. Many times the arrangements of school-based health centers, they are not money-making arrangements, right? You go into it because, you want to improve access, you want to maintain quality, you want to get to a lot of the barriers we talked about. And so many places will do this. And for example, in the case of hospitals, especially if they're nonprofit hospitals, and they have to demonstrate how they are using their community benefit dollars, for example, that may be a way that connected with community and with schools, you can have mutual benefit. So you're saying, we have identified that mental health or that asthma or that these particular health issues are a big issue in our community. I'm a nonprofit hospital who, by the fact that I get a tax break, must demonstrate how some of those dollars now are being used to benefit a community health issue. And I then can partner with my sponsoring agency or with the community to sponsor more school-based health centers. So that's just a way that but bottom line is, and sort of looking to my friend here on the left, that I'm one to say that sustaining these models, it's not always about money, that much of it is figuring out ways to institutionalize these really good practices. But your question was, how do we get more? And I have to say, then I come back to the money, and where the funding and how we have to shift those levers so that those who would be incentivized to provide more school-based health center care feel like they can at least meet some of the costs related to doing that. Otherwise, there's nothing in it for them besides the sort of moral argument, ethical argument.
Okay. One figure that I forgot to mention earlier when I first started out, between the IEP services and the Medicaid administrative claiming services, the schools in this country pull down about $4 billion in federal Medicaid dollars. So we are talking a chunk of money. I know from some examples of the state of Indiana where I worked, or Indianapolis school corporations, many of those turn their entire admin claiming checks over to the school-based health centers to help provide part of the funding and offset it. So, but the will is there. But the problem is that was the way it was originally set up. Now to go back in those school corporations and tell them, well, yeah, you can do this. Well, guess what? They're already spending that money on something else. So when you're looking at new ways to do it, and a school that's maybe not participating in admin claiming and they want to start a school-based health center, there may be some ongoing money to help fund it.
That's right.
Yeah, I had a little comment here. Thanks for clearing that up, John. I mean, there's a lot of opportunities that we are taking advantage of now, but, as we say, we're a little worried about what's going to happen with the repeal. Andrew earlier talked about the importance of families, about power, about children, and I believe that wholeheartedly the last couple of years. And when I say we, about around St. Paul Public Schools, we're 40,000 students. Our families are phenomenal, and we have to just help them navigate because they're not used to that. They're not used to our environment. A lot of our families have had poor experiences as students themselves, and now come in as parents, and only can reflect back to their experience that they had that was negative. So we got to advocate with them, stand with them together, and when we look at the St. Paul Public Schools, our operating budget's around $750 to $800 million. There's plenty of money available, believe you me. It's our responsibility to help them figure out how to spend it correctly. Just like any organization, they have their agenda. But when parents can stand up and say, this is what we believe is important, this is what we want. If you go to Capitol Hill, which is our most affluent school in St. Paul, that's where our lawyers and doctors, all their kids go. Do you think they have a full-time nurse? You're damn right they do. Yeah. Do you think they got a social worker? You're damn right they do. Do you think they got a librarian? Yes, yes, yes. Check all the boxes. Because the families won't stand up for it. They demand it. If you go to some of our schools where we're at 95 to 100% free and reduced lunch, that have a nurse twice a week, or no librarian, or no counselor. We have a counselor right here. And when the question is asked from a parent, why don't we have that? The administration just says, well, we can't afford it. We really would like to. And that's not acceptable. That's not acceptable to me. We have to remind them what the priorities are, and we get it from asking our families what it is. So we have Achievement Plus schools in St. Paul, and they have their wraparound services, which are phenomenal. But why isn't every school have wraparound services? Is it because do I have to be lucky enough to live in a certain area that my school might have access to wraparound services with a dental clinic, a nurse practitioner, speech clinician? So is it where I live is important within St. Paul? So now I got to plan where I'm going to live. I know when I bought my house, I couldn't even handle the pressure of I can live anywhere. I was like, oh my God, could someone point to an area? And our families don't have that luxury. Depending on where you guys live and where you're from, how is your district set up? We're neighborhood schools now versus, choice schools. So those things come in all the time. And when I think I talked earlier, the relationship that you're able to build with kids is important. They don't open up to someone once a week or twice a week. It takes years. When I was 12 years old, my brother was killed in a car accident, and it was devastating to my family and myself. I didn't talk to anybody. I didn't want to talk to anybody. But you know who I did tell? The custodian. He was someone I liked and let me use the phone to call for a ride. So when Andrew talked about training staff, he's right. It's everyone. And our responsibility is to remind anyone in a building that you are important. And your conversation might be minimal, but it could be a huge impact on our kids. Whether it's the nurse or the counselor or the custodian in my case, or the lunch lady in Andrew's example.
So the only other thing I would add to this is, there are great organizations that do a lot of advocacy around school-based health centers. So the School-Based Health Alliance would be a great resource for folks. They have a ton of toolkits. Oakland's health department, I can't remember what they're called because they're not called the health department, but they have put together a whole bunch of toolkits for how to embed health and education together. School-based health centers as a standalone are not, like Olga said, financially sustainable, but what they are is an access point, right? And so the language with providers, if you're going to work with an FQHC, is like this gets a family into your system, which allows you to now integrate them as a medical home, which does start to talk the language of financial stability. Another option would be to work with universities and medical universities to find opportunities for residents to get experience working with young people. Done a lot of work with like college students. We've got some big colleges, and when they walk into Baltimore schools, it's quick growing when you do that. And then I can't pass up Tom's softball that most of our parents don't have a choice in where they live. In Baltimore, public housing is gigantic, and when you map out the poor health outcomes that we have, because we do fantastic amounts of mapping in Baltimore, and then you overlay the red line maps of Baltimore from last century, they're identical. The impact that redlining had decades and decades and decades ago still plays out in the health outcomes in Baltimore today. When you look to Tom's point of the resourcing of schools, the under-resourced schools are all in the redlined areas because it doesn't just happen overnight. It happens and it's perpetuated, and then it gets to be other language starts to be used. And again, in the health department, we don't use terms like cultural competency. We don't stop at terms like disparity. Like, we are actively talking about, racism, and the way to work through that is through being culturally responsive, but it's first and foremost recognizing that institutional and historical things, and the impact that redlining had in Baltimore specifically is gigantic.
All right, thank you so much. There were a number of questions focused on how to afford things. So I do appreciate that a number of you are touching on just the different opportunities there. Because it's gotten brought up a few times, if there are other means you want to make sure you explicitly talk about again, how to afford, whether it's school-based healthcare centers, how to afford other well-being efforts and things, it is definitely something people are interested in. I will add one other really interesting question that came along that no one directly touched on, although you definitely, Andy touched on it when you talked about food deserts and, making healthy choices doesn't mean anything if, or suggests there's a choice to make. Someone brought up that obviously that nutrition is another really important component of a child's well-being. What is your reaction in your work to that? And then the specific question here is, how do we partner more with school nutrition authorities to address that as one of the comprehensive needs of students? So I'll let you jump into that, whatever on-ramp you want to use.
Well, as far as the funding goes, it is one of the unique things about the Medicaid funding. When it comes back into the school, it is unrestricted money. So it comes back to priority. The schools have the ability, the schools, the school boards, the community has the ability to use that money for whatever priority that they would happen to see. I can give an example, again, from my Indiana experience, where there was a school corporation that was generating like $280,000 a year in Medicaid money. And they allowed that money to flow back into the special ed department that was generated it and back into the OT, speech, PT, nursing departments to help support their staff, also to in-service training, to buy more equipment. The following year, the school board was having a major budget crunch. They decided they were going to pull this money back in and no longer revert it back. Well, so all those people that were doing, and this is extra work. There is work involved that you got to have access Medicaid. There's forms that have to be filled out. There's follow-up. There's audits. It's not like you're just getting this money for not doing anything. There is a lot of extra work that goes into it. So the staff that was doing all this work stopped documenting it. At least stopped documenting. They were still documenting their student progress stuff, but they weren't filling out the forms to claim the Medicaid. This is probably an appropriate place to talk about this too. Because of their teachers' union contract, the union backed the staff because nowhere in it was there was a requirement that they had to do all this extra stuff. So they went from pulling down $280,000 a year to the following year they pulled down like $5,000. Well, needless to say, the next year the school board negotiated back with the staff, the teachers. They did come up with, part of that money does need to flow back to the administration, but not all of it. So they come to some agreement on how that's going to be done. But again, it comes down to the priority. They can choose to use that money.
Direct action is a powerful tool from time to time.
So, again, I'm going to continue to pound on the community school drum. So this is a great opportunity when we start talking about community schools in Baltimore. We've done work that shows like for every dollar that the mayor invests in the community school strategy, there's a $3 return on that investment through either directly funded things or services that are leveraged at no cost to the school. Work in New York City out of Children's Aid has shown that it's much higher as far as a social return on investment. So when kids get out of school, that they don't need as many of the social supports and entitlement programs, really important. And that's sort of the mechanism because schools are tapped out. They're done. Teachers have a hard enough time being a teacher, a social worker, a surrogate parent, a counselor, all of those things that they just don't have the money to go out and do that. And in Baltimore, our school principals are CEOs. They manage their own budget. They get to choose their own staffing, 95%. They don't have time to find all of these other things, let alone balancing the fact that City Schools has a $130 million shortfall this upcoming school year. So direct action, our kids are either in front of City Hall or in Annapolis in front of the mayor saying, fix the gap, right? So when we talk about how we do those things, budget Band-Aids are not the long-term solution, right? Leveraging programs, getting grants, those are all fantastic Band-Aids, but until we find structural ways to fix the sustainability of funding, those things are not going to fix it. And I would say the same thing happens with nutrition. We were talking beforehand that a lot of our kids in Baltimore, the last meal they eat is the last meal they get at school. And so if they're not getting an after-school meal, or more importantly, in summer, if they're not able to get one of the limited spots for summer school, they have a harder time accessing food, right? But I'd go one step further to say that after-school meals, free breakfast, those are huge, necessary Band-Aids, that don't address the structural challenges of communities that don't have grocery stores, that don't have access to fresh food. It's necessary for us to provide those meals to kids and families, but until we fix the structural pieces of community that continue to sustain those deficiencies, we are just perpetuating. So I think that after school and the nutrition component is important in the short sight, but the long view is really that we have to change the way communities are comprised and the resources that are allocated in community in a sustainable, structural way.
I'm not going to talk about nutrition. I'm going to go back to the point a little bit about how to sustain potentially. And again, I know a little bit about this, but not a whole lot, except to say that, we know that there are kind of these regional health improvement coalitions, these kind of accountable health communities, where there may be these innovative kind of structures that are created, starting to work in some of the state innovation model states and others that might get CMS innovation dollars. And these communities are really identified, designed to think about community health goals and implement a strategy where you connect people to the health that they need. Because school-based health centers and nurses and folks in the schools, no one can argue they have an incredible access point. And not just because they're there, but because they're trusted. And not just because they're trusted, but because they're qualified. So they have an incredible opportunity, and those structures should not be designed without considering how one includes school-based health centers and nurses in them. And I mean, hopefully someone here knows of some examples. I wish I knew of examples where they really were organizing with those kind of pediatric specialists in mind as they're organizing these kind of incentive and sort of, the prevention-focused kinds of structures, because I think they're very well suited for that. And then could recoup and could potentially be a part, when there's savings, that gets funneled back to that organized structure, is another potential way. But again, one has to have a longer-term strategy and be willing to see the value and the benefit of school-based health centers and school mental health as part of that.
Fantastic. Thank you so much. John, I think let's go where you went. And you offered an instructive story on the power of contracts. And I have been at the bargaining table myself negotiating contracts that carve out time for nurses to do paperwork or for social workers to have time, because when you see a budget, it outlines your priorities, and when you see the list of duties assigned to people, that outlines what someone's priorities are as well. And when you conscientiously make time to do something, that is a signal that it is a priority, it is valued, and so when any group, certainly the appropriate day to talk about it, but certainly when a group of professionals withholds their labor in any form to make a point and to bring about attention to an issue they want remedied, in this case, they want to make sure that money that is for the well-being of children goes to the well-being of children. It is a powerful way to make your point, and so I want to use the spirit of that story, as knowing that I have some experience in this too, but knowing that you may all, and Tom of course has a similar vantage point to mine, but not perfectly, but all of you may have incredible vantage points to offer your perspective on the point of entry of unions in engaging and advocating for the promotion of the well-being of children as part of our, of part of our contract, as part of our, instructional day or work day. And when I say unions, I mean the paraprofessionals as well. So educators, licensed staff are represented by unions. Vast majority of non-licensed staff in our school buildings and others are also represented by unions. So those custodians, those food service workers, teaching assistants, educational assistants, and others. So I'd love for you to all, speak to the role of unions and your vantage point in advocating, promoting children's well-being as part of our union's work.
I can start. I had to look back on a few notes I had around social justice. And I think from the Federation standpoint, we are responsible to stand up for our students and our families and our kids and our communities with a small c. We are the voice sometimes when we're at the table to know what's right, because people have told us, our kids have told us, our families have told us what's important. So when a family comes and says, Tom, you're a great nurse, but you don't speak Hmong or Karen or Somali, like I mentioned, 60 to 70 different languages in St. Paul Public Schools. And I think that's what we do from the Federation standpoint is we remind everybody that healthcare is a right for everybody. And we should have access at multiple spots, ideally in a school, because that's where our kids go. Andrew shared it earlier. If you can't get to some of these places in Baltimore, you might as well not have a wonderful clinic. Years and years and years ago when I did my master's, I came up with this perfect school. And of course, it had all these things that we're talking about. This is where 50 million kids go every day to some type of schooling. It makes sense to have the services where the kids are at. Right. And I remember I partnered for a couple years with Children's Dental. They've been around for 110 years in St. Paul. And like Andrew mentioned, partnerships are hard. They don't happen overnight. When you have to screen 1,500 kids over 4 months and then come up with consent forms for them to sign, and then to get 20 families joined is labor intensive. And from a public health standpoint, I'm bummed out, right? Because I want like 150, 250, 1,000 kids. And the next year, of course, you have the implementation dip, so it's even less. But then maybe that third year, you have 300 families that get seen in my school with a dental provider, and the next year, 400. So it's the partnership and it's the hard work. But it goes back to we have to stand up from the Federation standpoint because our voice is heard, like John mentioned, sometimes louder. And Andrew's right. You get one parent at a school board, and it can change a policy, a procedure. We were going to move busing for kids, 5-year-olds, to a little bit early in the morning to be picked up at 7 o'clock. One parent went to the school board and said, if you think you're going to put my 5-year-old on the corner at 20 below in Minnesota with the snowbank 6 feet high to get run over by a school bus, the next day was squashed. Yeah. I could say that same message, and they wouldn't hear it. So it's bringing our families in from a union standpoint, standing together in solidarity, remind them that we're here with you, but we need your help to know what's important for you and be a voice with you.
I have not been a part of any of those negotiations, and I imagine it's quite hard work to kind of come to consensus. But one of the things that I have repeatedly in the work that I've been doing have been increasingly more concerned because it is a bigger and bigger gap. And I imagine that negotiating through contracts may be a way to start to tackle some of this, which is that we can't really promote children's well-being without simultaneously promoting adult well-being. And we don't do a good job, and I can say at least in the mental health world, of making sure that the adults that we've put in charge of supporting and shepherding and teaching and working with our young people have themselves access to, good health care, to wellness provisions, to saying we all should be paying attention to our wellness because we model it poorly, and then we ask our families and our kids to do things to maintain their health, and we're not doing it. I mean, right? All the health professionals are the worst at it. So, I just put that out there for those of you who are just in the trenches and figuring this all out, that, to the degree that we could, as a structural way, to say, could we start to really prioritize that in addition to, hey, these are the tasks that we're going to negotiate are the most important tasks, but among all of this, we have to remember I'm a human being too, and I need to be able to find ways to be connected to my peers, to supports that I might need, to my own mentoring and coaching, to whatever that is, and that in order so that I am 100% or as close to 100% as I can be, so that I can perform this duty. So I just feel I don't know who owns that. There's very few agencies or institutions that own adult wellness, and so it is really falling down. And in the children's mental health world, I find that that's one of the biggest advocacy points that we could make.
And as we've focused on school climate too in Baltimore, so we've done a lot of work trying to figure out what is school climate, how do we measure school climate, and then how do we improve school climate. Teacher self-care continues to come up, right? The teachers that I know that I consider good, right, is totally subjective, and maybe it's because we're like-minded, like those teachers take on the trauma that their kids live every day. Because you can't see a 5-year-old in your class who's hungry, who slept on the couch of somebody else's house, but they won't talk to you about it because they're scared of getting in trouble, whose mom comes in for us and they're leaning on heroin when they come to pick up the kid. All of those things, as a teacher, as a counselor, as a teacher, I can't turn a blind eye to that, right? And so how we use the numbers that unions have, the organizing power of unions to highlight the need for teacher self-care, not selfishly, right, because we all want free manicures or yoga classes or whatever it is, but because we know that teacher self-care, improves academic outcomes, right? When you're talking contract language, you have to tie it back to like what school boards, principals, all of those folks want to hear, and that, teachers who are able to take care of themselves are better able to take care of their kids, and kids that are most well taken care of are going to do better academically, and so tying all of that stuff together.
Not that I've had any direct relation with any negotiations with various unions but it's like when you're dealing with anybody, you got to get buy-in on what you're doing. And they need to be involved from the get-go and have an understanding of what you're doing. And of course, if they really believe it's the right thing to do, you're going to be able to do it a lot easier from an administrative standpoint than if you just come tell them, well, this is what we're going to do, this is why we need it, and you're going to do it. So you've got to start at the beginning. It was like the same deal with the parents. They need to understand. Well, just like any other community that you're asking them to do something, whether you're doing something for them or to them, which is sometimes the same, they have to understand. And the more they understand, the easier it is to get it done.
And the more, and getting those key decision makers to understand and really be at the table with you. Some respond to anecdotes or to stories from people they know. Some will respond to data, and we have more data. So now you can, so for those who need graphs and points of figures to say, how connected are these things really? We have more studies to show that adult well-being is connected to child outcomes, to child well-being, to child health, to school connectedness. So we, the evidence continues to grow, and we certainly, you certainly probably have a lot of stories yourselves that you could tell, but I think we have enough compelling information that we hopefully can be bringing folks together.
I want to thank our panelists very, very much. If you would join me in thanking the panelists, thank you for tuning in. I know, I want to thank you for joining this conversation, the Schenker conversation on promoting children's well-being. I think we have made the case in the last couple hours or so that how valuable and imperative this work is. I think we've also made the case that we are not there yet, and there are barriers. We've identified a lot of those barriers, though, and we realize they are not impossible barriers to break down. And I just have to close by saying how comforted I am to work alongside all of you in this struggle to realize healthy outcomes for all of our students, because you are amazing collective individuals collectively, and I look forward to every fight we win in the future for kids. So thank you, everybody. Thanks for joining us, and we'll see you next month.